So, Dr. Sana, I will give you 2 minutes so you can organize yourself. Your scenario for today is a 26-year-old lady coming to the early pregnancy unit with the complaint of PV spotting and a little bit of abdominal discomfort, not pain, only discomfort. How you will proceed with this case?
Okay, ma'am. Um,
मैम
It's a
scenario repeat करें.
it's a structure-based discussion. Someone note down the time for Dr. Sana. The scenario is a 26 years old lady coming to the early pregnancy unit with PV spotting and mild abdominal discomfort. How you will take this case towards the end?
okay, ma'am. Ma'am, first of all, I'll rule out the pregnancy.
Okay. Her urine pregnancy test is positive.
Okay. So, should I take the history or?
You will be assessed for information gathering, applied clinical knowledge, communication, and patient safety.
Okay, ma'am. Ma'am,
Yes, you can start.
ma'am, can
Ma'am,
you
may
give
I
me some
proceed?
time?
Let her do first. Later on, you can also. I will give you a different scenario.
Okay, ma'am.
Okay, Roxana.
Mm,
So that's why I ask all of you to come forward and present. Once this hesitation is gone, then you will be feeling confident, and then you can present any case, whether it's English, Urdu, or whatever language. Okay. How you will start the case? If it's a case-based discussion.
um,
Yes.
she has PV spotting and
Yes.
abdominal pain.
Yeah.
So, I'll ask about her symptoms
Mm-hmm.
and
Okay, let's suppose this is the
the,
patient. This patient is coming to your clinic.
mhm.
Now, whatever you are asking from this patient in your clinic, you start asking in English. You want to reach to the diagnosis.
I'll first of all, I'll ask the biodata,
Mm-hmm.
name, age, her education, and what does she do. Then active, what are her active complaints?
Mm-hmm.
Um, then I'll ask about her LMP.
Excellent. Mm.
Uh, After that, I'll ask about associated relieving and aggravating factors.
Mm-hmm.
Also, then I'll ask about any um, previous history of um, herparity.
Okay.
Yes, I'm very disorganized.
It's okay. Still, you are asking. You try to come
Yeah.
forward. Okay.
I'll ask about her cycles, whether they were previously regular, irregular,
Okay.
and also previous medical and surgical history.
Yes.
Um,
Specifically, what you
I'll,
want to ask in the medical and surgical history for such patients?
um,
Okay.
mm,
Mm-hmm. Going forward.
any previous history of um, I don't know.
Okay. Then, when you have taken the history from your patient, And such patient is coming to your clinic, how you proceed further? Do you do any examination for such patient?
Yes, yes, I do general physical examination,
Hmm.
um, and abdominal examination, and pelvic examination.
Okay.
So in general physical
Specifically,
examination,
specifically in abdominal examination, what you want to look for?
any tenderness
Excellent. Anything else?
and um, um, any mass.
Okay. So why you wanted to look for the mass? What you are suspecting? What are the thoughts in your mind that you are looking for the mass?
Um, any fibroid or cyst, etc. And
Okay.
for tenderness, I was suspecting like ectopic pregnancy.
Mhm. Okay. Excellent. You are
Yeah.
suspecting. Okay. Dr. Bakhtawar in the chat box is saying that she wants to look for the signs of peritonitis. So, Dr.
Mhm.
Bakhtawar, what features in the patient history is pointing towards the peritonitis? Why you want to ask about the peritonitis?
मैम रिप्रोडक्टिव एज पेशेंट है और इसको जो है पीवी स्पॉटिंग और माइल्ड डिस्कम्फर्ट है
But
तो
urine
उस
pregnancy
वजह
test is
से
also positive.
यस मैम तो आई विल रूल आउट रप्चर्ड ectopic pregnancy.
Okay. Okay, Dr. Sana, coming back to
Yes, ma'am.
what investigation you want to do for your patient?
Ma'am, first of all, baseline investigations, complete blood picture, her HBS, HCV, HIV, and urine complete examination. Also, in specific investigations, I'll ask for uh, TVS and beta HCG.
Okay. So
And
beta HCG is 900
mhm,
and transvaginal, what you want to ask about?
uh,
In transvaginal scan,
mhm.
what specifically you want to look for?
Ectopic pregnancy.
First of all, any intrauterine pregnancy. Okay.
Yes, yes,
And
exactly.
now the scan findings are that the patient is there is no intrauterine pregnancy located, no extrauterine pregnancy located, no adnexal mass, no free fluid. How you will
Okay.
proceed further with this case? What do you think the diagnosis for this patient is?
No intrauterine mass and no extra. Okay.
There is no adnexal mass, no free fluid, no intrauterine pregnancy located. So
Uh,
only the 12 mm of endometrial thickness is there.
uh,
So
uh,
what do you think this?
I'll
Hmm. What is the
uh,
diagnosis?
this pregnancy of unknown location.
Okay. So how
I'll
you will
repeat this.
proceed further with this case?
Uh, I'll repeat the scan.
Okay, why you want to repeat the scan?
Uh,
Mhm. Okay, any other investigation you want to repeat?
Ma'am, no idea.
Okay. Dr. Homa is saying she wants to check the serum progesterone level. Is there role of the serum progesterone in the POL? Is there any role?
नो मैम नो रोल.
Okay. Uh, So what is the management plan for this patient?
Um, Ma'am, we need
Usually,
to,
when you get a patient of pregnancy of unknown location, how you proceed in your clinics, in your hospital settings, what you do for these patients.
ma'am, need to follow up with beta HCG.
Okay, then okay. Okay, so anyone else who want to do the same scenario? Thank you, Dr. Sana. Up
Thank
till now, at least you tried. So I will point out certain things. Now, then after that, you will know. Okay, so Neela is saying, see the pattern increasing, decreasing, or suboptimal. Yes, but how you will tell your examiner, Sunila? This is what I am telling you. All know the things, all of you have the knowledge, but how you will apply this knowledge in a beautiful manner to impress the examiner actually. If you can impress the examiner, only then you can get the marks. Okay? Because everyone is coming in, they are telling them the same knowledge. What makes you different? How you present yourself there. Okay? Anyone else who want to do the same scenario?
Yes, ma'am, मैं करूँगी. I will do.
Dr. Bakhtawar, is that you?
Yes, ma'am.
Okay, so the same scenario I'm giving to you. Then I will point out the mistakes for Dr. Sana also because I have noted them on a piece of paper. And then Dr. Bakhtawar, after you complete your scenario, okay? So the same scenario, 25-year-old lady coming to your clinic or early pregnancy unit. I am giving just a small scenario instead of a lot of information because first I want you to know about the template of the early pregnancy module. Once you know the template of the early pregnancy module, then you can rule out the different diagnosis and you can have a list of differentials in your mind and then you can go to the certain diagnosis. But first you want to, I want all of you to know how to reach to certain diagnosis of the early pregnancy module, right? So 25-year-old lady presented to the early pregnancy unit with PV spotting, positive urine pregnancy test, and mild abdominal discomfort. How you will proceed for this patient?
Okay, ma'am. First of all, I will introduce myself after mutual introduction and confirming the details from the scenario. And I will ask the missing biodata, including name, age, and parity, and education, occupation, and I will ask her about the last menstrual period and blood group and RH factor. Then I will ask her a focused history from the presented complaints. As my patient has PV spotting and there is also a mild abdominal discomfort and she has missed period. I will ask her about the uh, duration, onset, severity of the symptoms, and then I will ask her about the any complaint of uh, burning maturation and urgency, frequency of urine, and is there any discharge and color, amount color associated with itching or not, and whether any associated foul syphilitic discharge or not. And I will ask her about the fever. Is there any fever? And then I will ask her about the amount of bleeding and the duration of bleeding. And then previous is there any previous episode, previous history of ectopic pregnancy or
Yes, she
previous
has a
history
previous
of
history of ectopic pregnancy as well.
okay, ma'am. And is there any previous episodes of pelvic inflammatory disease? And is the patient using any contraception previously or now?
No, no
Uh,
contraception. She had one past history of chlamydia infection when she was 18 years old.
Whether she was treated for chlamydia previously or not?
Yes, she has the treatment.
Okay, ma'am. Then I will ask her about the any what food she had taken last night. Is there any diarrhea or any episode of vomiting nausea from the last night or last days?
Mm-hmm.
Is there any symptoms of gastroenteritis? I will rule out the gastroenteritis from the patient. Then I will ask her about the past obstetrical and past obstetrical gynecological history and any family medical and medical surgical history. I will also take
Past
the
surgical history, she has a history of appendectomy.
okay, ma'am. Then I will ask her about the social support and any support at home
Yeah, she's
and
well
what
supported.
and any drug allergy or using any medicines previously.
No.
And then I will do her general physical examination. I will check her BMI and vitals, blood pressure, pulse, temperature, respiratory rate, and
She is vitally stable.
I will check for signs of anemia and any cardiovascular and breast examination.
Okay. So
And I will do her per abdomen. Yes.
why you want to do cardiovascular examination in this patient? Because you have just 10 minutes, you have to complete within the 10 minutes. So you have to take the targeted history. So
Okay,
you
ma'am. I will do
have,
her per abdominal examination, in which I will do her inspection to check for any scar mark, whether it is a midline or because patient has previous history of pregnancy. I will check for scar mark whether it is transverse or midline, and I will do her superficial palpation to check for any signs of tenderness and deep palpation to check for any visceromegaly or any rebound tenderness if there are not orthotic present or
what
not.
you are suspecting, you why you want to check for visceromegaly?
Visceromegaly
Hmm.
as a routine examination.
Okay, continue.
I will check for I will do her I will check for any abdominal or pelvic tenderness from the deep palpation. Then I will do her local examination to check for any discharge or bleeding coming out from the vagina. And then I will do her perispiculum examination to check for the health of the vagina cervix. And then I will do her bimanual examination to check for any cervical tenderness or adnexal tenderness, and also check for the uterine size, position, mobility, tenderness, and any adnexal pathology.
She has just a positive urine pregnancy test. Why you want to check for the uterine mobility, uterine size, uterine tenderness? You can just say by pelvic examination, I want to check for cervical motion tenderness, because one of the differential diagnoses in your mind is the ectopic pregnancy. Early pregnancy with abdominal pain and PV spotting. We have 2 to 3 differential diagnoses in this scenario. Okay.
Yes, ma'am. Yes.
Okay, then
Then, ma'am, are you asking about the why I am doing the bimanual examination?
bimanual examination I know because you want to check for the pelvic or cervical motion tenderness. But you
Yes,
said
ma'am.
I want to check for the size of the uterus and mobility of the uterus. For in this scenario, the size and mobility of uterus is not important. You
Yes, ma'am.
can just say, I want to check for the cervical motion tenderness or any pelvic tenderness. Instead of using long sentences, you can simplify it to the examiner, and you have to make it compact and short so that you can complete easily within the 10 minutes, and you tell each and everything, and you touch each and every point and reach till the end of your station within these 10 minutes. Okay.
Okay, ma'am. Yep.
Okay, then further.
Then I will do her. After that, I will do her investigations. Uh, I will proceed towards the investigations. I will do her first baseline investigations, complete blood count, including hemoglobin, total leukocyte count, and platelet count, and then blood group and RH factor, and random blood sugar, and also urine complete examination to see the first protein and sugar, and viral markers, hepatitis B surface antigen, hepatitis B surface antigen, hepatitis C virus, and then I will do her specific investigations, including her beta ICG and transvaginal ultrasound scan.
Okay, then
Then after that, will you provide the investigations that I told asked for?
okay. So how you will manage this patient? What do you think is your diagnosis?
Ma'am, beta ICG or
Beta HCG is
TVS ma'am?
900, the same. Beta HCG is 900, and the transvaginal scan is showing the no intrauterine pregnancy, there is no adnexal mass, and no free fluid and no probe tenderness.
Yes, ma'am. Now I will manage the patient. I will empathetically approach the patient, and I will break the news to the patient in a very sympathetic way. I will tell the diagnosis that till now, from the investigations and history and examination, the patient, most probably the patient has a pregnancy of unknown location.
Okay. So what is the
I will
pregnancy of unknown location?
in this pregnancy, the patient is a pregnant, but their location of the
Is it
pregnancy
is
is
it a
not till.
diagnosis? The pregnancy of unknown location, is it a diagnosis?
Yes, ma'am, it is a diagnosis till now.
Mm. It is not a diagnosis, it is a medical term which can lead to one of the few things. Like it could be an intrauterine pregnancy, it could be an ectopic pregnancy, or it could be a miscarriage. So it is not a diagnosis, it is a medical term which can lead to any of these. Okay?
Yes, ma'am. Yes, I will. I will counsel the patient that this pregnancy can end up whether it can proceed towards the normal intrauterine pregnancy. Maybe it can end up in the miscarriage, or it can proceed towards the ectopic pregnancy. So I will follow the patient with the serial beta ICG and transvaginal ultrasound scans, and I
So
will
you will be doing
also
ultrasound also for your patient every 48 hours?
no, ma'am. I will first do her beta ICG. When her beta ICG levels crosses the greater than 1,000 international unit, I will do her TVS to check for any intrauterine or ectopic pregnancy.
Okay.
After that, I will also see the patient clinically, any for any sign and symptoms, and I will also um, her then after that I will uh, फिर क्या करना है?
Okay, how you will proceed further?
Further, I will ask the patient to do her beta
Can
CG after
you
48
be a
hours.
bit louder?
Then I will ask the patient I will tell the patient to do her beta ECG after 48 hours. If the beta ECG is to check whether beta ECG is rising or decreasing or whether it is suboptimal. So I will treat according to the beta ECG reports. If the beta ECG becomes greater than 1000 international unit, I will do her transvaginal scan to check for any intrauterine or ectopic pregnancy. If it increased greater than 60%, beta ECG after 48 hours greater than 66%, it means it can most probably proceed to the viable intrauterine pregnancy. If the beta ECG falls greater than 15%, it means it most probably the pregnancy will be non-viable pregnancy,
So
will
what
end
you
up
will
with
do
the
in this
miscarriage.
case, if it's a non-viable, how you will follow your patient?
After non-viable means greater than 15% fall.
Okay,
Then
so if it is
beta ECG.
more than 50%
More than
fall,
15%
what you will do
falls,
then?
then I will do her I will also check her clinically patient's signs and symptoms, and whether if the patient is stable, I will do her beta ECG weekly till beta ECG less than 5 international units.
Okay, you will be doing a weekly beta HCG. Okay, so if it is less than 50% decline and less than 63% decline, what will you tell to your patient?
I will tell the patient that most probably the your pregnancy is proceeding towards the falling pregnancy, and it means your pregnancy is becoming scary.
Sorry, come again.
मतलब pregnancy will miscarry.
No, if it's
Miscarriage
not less than 50% decline or not,
less than 50.
yes, or if it's not increasing more than 63%.
It means it means the beta ECG is suboptimal.
Mhm.
Then I will follow the patient and do her beta ECG every. Then I will do her beta ECG,
Mm-hmm.
and after 48 hours, if it remains suboptimal and not increasing greater than 1000 international unit, then increasing greater than 1000, then I will do her transvaginal scan after 1 week, or if beta ECG greater than 1000, I will do her transvaginal scan to check for ectopic or intrauterine pregnancy, and I will also check her signs and symptoms
If
of
the patient is having suspicion of ectopic pregnancy, are you going to do her transvaginal scan after a week?
मैम जब उनका बीटा ECG 1000 से 48 आवरली बीटा ECG करवाती रहूंगी, और जब उनका 1000 से ज्यादा लेवल आ जाएगा ना, तो उसका मैं ट्रांसवेजाइनल सोनोग्राफी करवाऊंगी.
Okay. Is this in the
ओके,
guideline? Is
टीवीएस
this written in the guideline?
मैम 1000 से ज्यादा होता है तो टीवीएस में नजर आ जाता है जैसे बीटा ECG
Okay.
अगर 1000
Okay, I
से
will
ज्यादा
tell you
होता है.
how you will explain to the examiner about this thing. Okay, if it's more than 63% rise, then what you will tell your patient?
That most probably the pregnancy will be viable, will be proceeding towards the viable intrauterine pregnancy. Then I will do her TVS to check for any intrauterine pregnancy and viability of the pregnancy.
Okay. Is there any role of third beta HCG after 48 hours? Like one you have done, that 48 hour you have repeated. Is there any role of any third beta HCG after 48 hours?
Third beta ECG.
Like if your patient is in the gray zone, that is the suspicious ectopic pregnancy, so would you do any third beta HCG after 48 hours? Because you will confirm this, that patient is in the gray zone after her 48-hour beta HCG. So once it is, you
Gray
have
zones
done
means
and you are, Mhm.
मतलब yes ma'am, it means pregnant beta HCG suboptimal जा रहा है इसका मतलब.
No, I'm just telling it is let's suppose you have done your 900, it was beta HCG was 900, and then after 48 hours you repeated it is 950. So what you will do for this patient?
Ma'am, I will do her beta HCG. I will do her serial beta HCGs until it is greater than 1000, or I will do her beta HCG 3 times 48 hourly. If it is suboptimal, then I will repeat her TVS after that to check for any pathological or intermittent pregnancy.
Okay. So how you will be sure that the ectopic
Three
pregnancy is
times
completely
मतलब
ruled out?
मैम ectopic pregnancy अगर completely ruled out
How
हो
you will
रहा
know that the ectopic is completely ruled out?
मैम
In a patient with PUL,
मैम 3 measurements बीटा HCG के लेंगे, अगर suboptimal जा रहा है, TVS पे कुछ नहीं आ रहा, तो
no,
हम
how you will
देख
explain to the patient?
सॉरी मैम.
Okay. So the next question is,
Yes.
what will happen if the patient is diagnosed with an ectopic pregnancy? This is my last question.
Then I will empathetically approach the patient, and I will tell the diagnosis to the patient that your pregnancy is not in the normally pregnancy occurs in the uterus, but in your case pregnancy has not occurred in the uterus. It is outside the uterus, in the tubal tubes, fallopian tubes. It has occurred, and I will check the signs and symptoms of the patient, whether patient is clinically stable or not. I will treat according to the patient's symptoms, and whether her previous ectopic pregnancy, how her previous ectopic pregnancy was treated, whether salpingectomy or medically, surgically, medically, or expectant management previously was done. So I will do her management according to previous and patient's
Okay, Dr.
condition.
Bakhtawa. Okay, I'm stopping you here. You have almost taken more than 20 minutes, approximately 40 minutes. Maybe less than 40, but more than 20 at least.
Yes, ma'am.
So let me explain to you. One thing is clear, that you have to be compact, concise, because it is just 10 minutes. You should be focused, you should be taking the targeted history and all the knowledge that you have gathered from the guidelines or books or whatever you have read. But nowadays mostly everyone is just following the guidelines because everything is coming from the guidelines, right? So all these things should be on your fingertips. There is no shortcut to success in this exam. The only thing that you have to do is the hard work, right? Dr. Sadaf wants to try also. Yes, Dr. Sadaf, you can unmute yourself and then I will tell you how you will go with this station. Okay, Dr. Sadaf, but I will be
Okay,
giving you 10 minutes, right? Someone note down the time for Dr. Sadaf. So
ma'am, please repeat the scenario.
Scenario is just simple scenario. 26-year-old lady with PV spotting, with mild abdominal discomfort and urine pregnancy test is positive, presenting to early pregnancy unit.
Okay. First, Assalamu alaikum. I'm Dr. Sadaf and I'm ready for the structural discussion of my case. First of all, ma'am, I will introduce myself to the patient, and after confirming the identification, I will ask about the missing details. That is the name of the patient, age, and the parity, last childbirth, LMP. Is she sure of dates or not? And
Excellent.
since how long she is married, and education and occupation. And then I would ask that how she confirmed her pregnancy, and is this the spontaneous pregnancy, or she conceived on the any medication, or is she have any symptoms of pregnancy like nausea, vomiting, any and as she is came with a PV spotting. So I want to ask, is this the first episode, or is she need to apply a pad or not, or is she done any ultrasound till now or not? Any history of the syncope and the shoulder tip pain, or the dizziness along with this pain? And then about the pain, I want to ask the onset, duration, and the severity of the pain, and whether the pain is relieved or not. Or then I would ask that any history of the vesicular bleeding to rule out the molar pregnancy, and then any ultrasound has been done, and if ultrasound has been done, then what is the location of the pregnancy? And then about the gynecological history about her LMP, and the regularity of the cycle, dysmenorrhea, dyspnea, and the intermenstrual bleeding and postcoital bleeding, and contraception used in the part. Any IUCD has been taken by the patient or not in the past, pap smear report. And then about the parity of the last child births, the mode of the delivery, any history of the ectopic pregnancy in the past, or uh, about the gynecological history, any medical disorder she have, any surgical history of concern like appendectomy or any other surgery, and then any tubal surgery in the past, or then about the socioeconomic status, and the personal history of smoking or any other addiction or any drug allergy. I'm
Excellent.
done with my history. Any positive finding?
So she has a history of PID previously, chlamydia, and then appendectomy 2 years back. One history of past ectopic pregnancy. Otherwise, her smears are up to date, but she is a smoker. And this by LMP, this pregnancy is around 5 weeks, 3 days.
Okay, ma'am, I want to ask that how she treated how she treated in the past for the ectopic pregnancy. Is the tube is removed, or any other medication she took, or what?
No, it was just an expectant management.
Okay, it was just an expectant. Okay, ma'am, or since last ectopic pregnancy, how many years back?
It was 3 years back.
Okay. Then I want to examine my patient. Can I proceed?
Yes, sure.
Okay, ma'am, I want to see the BMI of my patient and the BP, pulse, temperature,
She's
respiratory
vitally
rate.
stable. BMI is with normal limit.
Okay, then I want to do the per abdominal examination, in which I want to see any tenderness in the abdomen, any mass. Or
There is
then
no
I want,
tenderness.
and then I want to do the pelvic vaginal examination to know the any cervical motion tenderness, any fullness in the furnaces.
No, there is no cervical motion tenderness.
Okay, I want to see the pad of the patient if applying, because she is complaining of spotting. So I want to do the per speculum examination if patient allow.
Yes, on per speculum examination, there is a streak of blood. No fresh blood is there, and no clots or no passage of tissue, nothing.
Okay, then I want to proceed for the investigation. In the investigation, I want the complete blood count, hemoglobin gram per deciliter, total leukocyte count, platelet count with time and date, blood group and RH factor, urinary
All
for the
within
98
normal
plus,
limit.
and the OGTT report.
She has not done an OGTT.
Okay, and hepatitis B and C status. Then I want to proceed for the specific investigation. In the specific investigation, I want the transvaginal ultrasound to know the exact location of the pregnancy, and any fluid in the pouch of Douglas, on the endometrial thickness.
Endometrial thickness is 12 mm. There is no free fluid. There is no probe tenderness. Adenexa are clear, and no intrauterine pregnancy is located.
Okay, ma'am, I want to know the beta HCG levels of my patient. Any serial
It's
beta HCG?
900.
900. Okay, ma'am. Should I proceed for the management?
Yes, sure.
Okay, first of all, I will counsel my patient empathetically, as this is a very distressing condition for my patient. So I will give this emotional support, and I will ask her if she want to be with someone, then she can. Then I will allow. her to do, and then I will explain empathetically that in the history which is provided to me and the investigation which is given to me, this is the most likely the probable diagnosis is the from now is the pregnancy of unknown location, because the pregnancy is not located in the ultrasound. But for the further, I would support her that for the further investigation, I will admit my patient, and I will involve the multidisciplinary team in which the senior obstetrician and the radiologist and the psychologist involved. And then I would explain my patient that I will follow her with the beta hcg report to locate the pregnancy and to know whether the pregnancy is intrauterine, extrauterine, or whether she is going to
I
abort the
have
pregnancy.
already given you the beta HCG. It is 900. And
Okay, ma'am.
then there is no intrauterine. How you will proceed for this specific patient?
Ma'am, I will repeat the beta HCG after 48 hours of the first beta HCG, and then I would see that whether the beta HCG is increasing or decreasing. If it is increasing greater than 15% or whether it is doubling, then it is a good news for my patient that probably this pregnancy become the intrauterine. But if it is not,
63%. Dr. Sadaf, 63%.
okay, sorry, madam. Yes, greater than 63.
That is for ectopic pregnancy. Okay.
Yes, and if it is not increasing or not decreasing, but if there is a suboptimal levels, and I want the three measurements showing the suboptimal levels, whether the plateauing or fluctuating pattern, then I will repeat the transvaginal ultrasound to know whether it is persistently pregnancy of one location, whether it is the ectopic pregnancy. According to that, I will further manage my case.
So
And
you did your third beta HCG and it is 950. How you will proceed for that patient?
first is 950, second one is also 950.
The first you did, it was 900, right? This
Yes,
means the first and the second after 48 hours you have done, it is 900 and then 950, and the third one is still 950. How you will proceed?
madam, if then my diagnosis, then I will repeat the TVS, and if the in the repeat TVS whether there is any sign of the ectopic pregnancy or not.
Okay, so you want to repeat the TVS after third beta HCG or after second?
After third.
Okay, okay, then
If there is no the signs of the ectopic pregnancy or ectopic pregnancy not visualized in the TVS, then probably it is the persistently pregnancy of unknown location. Then I will consider the medical management. I will counsel my patient that the pregnancy is in the body, but it is not visualized in the ultrasound. So the best treatment for this is to give the injection methotrexate after the CBC and LFTs, and then I will give the injection methotrexate, and then I will repeat the further beta HCG on the first day and then the fourth day to know the levels of the beta HCG,
okay.
whether it is decreasing or not. If it is decreasing greater than 15%, it means the pregnancy where it is located, it becomes falling. And but if it is not increasing sometimes, so then the second beta HCG is also required by the patient.
Okay. Then
then I will follow the beta HCG till then it becomes less than 10 international unit.
okay, then
And then
so you will then in the end you will give patient information leaflet to the patient.
yes,
And then connect her to some support groups. Okay.
yes.
So excellent. Most of the points you have covered. Few of the points I want to tell you. Otherwise, it was an excellent presentation. This is the way you should be fluent with each and every of your station. So
Thank you.
if you are telling your examiner in this way, you will surely pass this exam. Because, and then few of the things I want to add, there is no role of MDT here. You can just say, I will seek an opinion from the senior obstetrician. You can say like this, okay? MDT usually for cancer patients, for some complicated cases. So this is an early pregnancy. You can not use the word of MDT. You can say that I will involve the radiologist, senior. MDT word is specifically when you are managing the oncology patients or you are managing some complex maternal medicine patients. Rest of the things you have done very well. All of you should start your scenario just like that. Then my name is Dr. Raman or whatever the name you have. And I'm one of the exam candidates today. I have read the scenario and I'm ready for the structured discussion. As I see from the notes that my patient is a 25 years old lady with a positive urine pregnancy test and mild abdominal pain. So after confirming her name and age, I will proceed with the targeted history. First of all, I want to know about her last menstrual period, her parity, just like Dr. Sadav said, if any previous pregnancy, previous ectopic pregnancy or any miscarriage. Then I want to ask about the PP bleeding, whether there is any passage of the clots or any tissue, because you want to rule out about the any complete miscarriage, any molar pregnancy. So you can say about vesicular tissue, clots, or the passage of tissues. Now I want to confirm about the pain, whether it is a crampy or abdominal pain, it is a continuous pain, what is the nature of the pain, and is it associated with any dizziness, syncope, shoulder tip pain. And I also want to know about whether she's having any diarrhea or any disturbance in her bowel movements since she started to have this pain, because sometimes ectopic can present with diarrhea also. Then you have to and tell about past medical history. Specifically, I want to know about the history of PID, past surgical, specifically appendectomy, tubal surgery, any pelvic or abdominal surgery previously. Is she on any contraceptive? Most likely copper IUCD. I want to ask about any intrauterine contraceptive device. I want to know whether she is up to date with her pap smear, and I will signpost the patient, or I will ask by pardon me about asking about any sexual partners, multiple sexual partners, smoking history. Then I would like to proceed for the examination of my patient, about the general look of the patient, whether she's oriented, how is her current condition, and then I will proceed with the abdominal examination. Specifically, I will be checking for any tenderness, because I am suspecting ectopic pregnancy, because she's presenting in early pregnancy with an abdominal pain. So before asking by the examiner, you should give your logics why you are asking about these things. Then I will proceed with the vaginal examination to check specifically for pelvic motion tenderness and cervical motion tenderness or any discharge. Now I want to know, and then the social history you can quickly ask about allergies, social history, and blood group for every pregnant patient. Now I want to move towards the investigation. Apart from the routine investigations, I want to ask about the beta HCG of my patient, because she has a positive pregnancy test, and only the beta HCG will help me to decide for her further management and confirmation of pregnancy also. So then I will go for the transvaginal. I want to know about the uterine thickness, whether there is any intrauterine pregnancy or any pseudosac or any gestational sac located or any collection of fluid within the uterine cavity. I want to know about the any adnexal pathology, any adnexal mass, free fluid, is it present or not, or any collection, right? And if there is any uterine pregnancy, I want to know about its the current gestational age of the patient. Okay, so once you have done these things and she gives you the details of the patient, then you can say from the history, examination, and investigations, it's most likely that this is the pregnancy of unknown location. So I have to communicate these diagnosis or this condition to my patient empathetically. I will ask her if she wants someone to accompany her, and then I will tell about the pregnancy of unknown location. So I will be telling my patient that this is a medical term, it is not a diagnosis. There is a chance that the pregnancy could be the normal pregnancy could be growing in the future inside the uterus or inside the womb, or there is a chance that this is a failing pregnancy, or there is a chance that this pregnancy is an ectopic pregnancy. So all these three options are there. So depending upon the condition of my patient, if my patient is, this is very important, if it is PUL, you have to say these words, depending upon the condition of my patient. As the patient is having only mild PV spotting, she is vitally stable, So I will go for beta HCG 48 hours apart. So there is no need for my patient to be inpatient, right? And then I will check the trend of the beta HCG. If it's rising more than 63% after 48 hours, I will explain to my patient that most likely this is an intrauterine pregnancy, although the diagnosis at the moment is not confirmed. So that's why I will offer a transvaginal scan to my patient to confirm the location of the pregnancy within 7 to 14 days, or earlier if her beta HCG is more than 1500. If on the scan at 7 to 14 days, it's confirmed that the intrauterine pregnancy is there, and then I will put her on routine antenatal follow-up visits. Otherwise, if no pregnancy is seen inside the uterus, then I will immediately ask the senior obstetrician or gynecologist to repeat the TBS, and then we have to manage this patient as an inpatient until her pregnancy is confirmed, okay? Whether intra, extrauterine or whatever is confirmed. The second option for this patient would be there is less than 50% decline and no, sorry, less than 50% decline and less than 63% incline, then there is a suspicion of ectopic pregnancy. So this is the gray zone. So I'm worried about my patient. So that's why I will ask her to review again within 24 hours to the early pregnancy unit or the hospital. And then here we will repeat the TVS, not after the third beta HCG. Then we will repeat the TVS, whether the viable intrauterine pregnancy is there or no. If not, then it is most likely to be the ectopic pregnancy. But again, the third beta HCG depends upon the level of stability of my patient. If my patient is vitally stable, then I will do the conservative management and I will do the serial beta HCG weekly or depending upon the patient condition until it is less than 5 international unit. But if on the repeat third beta HCG value, it is high, it is persistently high or it is increasing, then we need to do a laparoscopy for the patient. Even if she is stable, and there are rising trends, we want to do the diagnostic laparoscopy for the patient to confirm our diagnosis. But if the decrease is more than 50% at 48 hours, the pregnancy is unlikely to be to continue. Most likely it is a failing pregnancy, but still we want to confirm it. That's why we will be doing a urine pregnancy test after 14 days. If it is positive, then the patient has to report back again to the early pregnancy unit. If not, then she can stop the follow-up. Okay. The other thing is, then I will explain to my patient that at this moment, when if the examiner asks you, because I asked this question, I will explain to my patient, if she asks that ectopic pregnancy, how she will confirm that ectopic pregnancy is ruled out. So you will tell that I will be only able to completely rule out the ectopic pregnancy when we see a pregnancy in the womb on the scan, or your pregnancy levels become negative, pregnancy hormone level become negative. So these are only two options in which we will completely rule out the ectopic. This is a very simple question, but usually it is difficult for the student to answer. Okay, and if at any time you are diagnosed with ectopic pregnancy, then we have a different treatment option. If the examiner asks during the structured discussion, you can explain. If they does not ask, then you can leave it. Okay, but usually if you complete everything in time, sometimes they tend to ask, sometimes they don't ask. Okay. So this is how, and then I will give patient information leaflet to my patient. I will calm her if she's anxious. I will answer all her questions, and then I will connect her to the support groups. Okay. So this is how.
मैडम
Yes.
मैडम आई हैव अ क्वेश्चन कि जो प्रेगनेंसी ऑन लोकेशन का मैडम टॉक है ना, उसके अंदर ये लिखा हुआ था कि जो 66% राइज होगा, तो 66% से ज्यादा, तो इसका मतलब है कि वो इंट्रा यूट्राइन प्रेगनेंसी है, और जो सब ऑप्टिमली राइज्ड होता है
उसमें 13% दिया है टॉग में, 13 और 66, बट द टॉग इज अराउंड समवेयर 2012 का टॉग है वो, और नाइस गाइडलाइन जो है वो बिल्कुल रिसेंट है, सो वी हैव टू फॉलो द नाइस गाइडलाइन, नॉट द टॉग. ओके,
ठीक है. और मैडम ये जो 3 मेजरमेंट वाली बात है कि सब ऑप्टिमल लेवल्स में 3 मेजरमेंट्स चाहिए, तो मतलब वो भी इस तरह नहीं है कि पेशेंट की कंडीशन पे है ना कि हम 3 तक
नहीं, ये
जाएं।
आप दिस वन आई हैव अ रेफरेंस ऑफ strategy and a nice guideline. So if the rise is suboptimal or the fall is suboptimal, and then you have to call the patient within 24 hours to the early pregnancy unit to repeat the TVS. Here, if you still do not see any pregnancy, but patient is hemodynamically stable and vitally, and the examination is also normal, then you will repeat the third beta HCG. If the third beta HCG is like same static or falling, then you can manage this patient conservatively by the serial beta HCGs until it is less than 5 or less than 10 or until it is negative. But if there is a rise in the beta HCG or there is a rising trend, rising pattern, then if the patient is stable, still you have to do the diagnostic laparoscopy, because why the beta HCG is increasing? If we are not able to see the pregnancy, it is somewhere there and it is growing, so we want to go for the diagnostic laparoscopy. Okay.
Okay ma'am, thank you.
Okay, any other question related to this scenario?
मैम 3 मेजरमेंट्स वाली बात रिपीट करें, 3 मेजरमेंट्स लेंगे।
There is no need for 3 measurement. Look, first measurement you do when you see this patient. Then after 48 hours you do again to confirm your diagnosis. Then after 48 hours the patient fall in the category of the ectopic pregnancy. So straight away you will call this patient within 24 hours to the early pregnancy unit, and then you will decide for the third beta HCG depending upon the condition of the patient. If she is hemodynamically stable, then you do third beta HCG. If there is the falling trend, then you keep on doing the beta HCG until it is negative. But if there is the rising trend, then you go for diagnostic laparoscopy. Okay? Anything else you want to ask? Any question related to the extended talks, anything related to the scenarios, anything related to the structure discussion or role player station,
मैम
anything?
थर्ड बीटा एचसीजी अगर सब ऑप्टिमल ही रहे तो उसमें भी डायग्नोस्टिक लेप्रोस्कोपी करेंगे। थर्ड बीटा एचसीजी वो भी
Suboptimal,
सब ऑप्टिमल ही रहे,
फिर भी हम डायग्नोस्टिक कर सकते हैं. Then depending upon, sometimes with third beta HCG, sometimes if clinically you say, but this I have never read in any guideline, but clinically you can go for methotrexate also, because this is practice in certain hospitals. And this is also given in the previous talks also. Strategy also says this. If the beta HCG is static, not rising, static, you can go for diagnostic also, and you can also go for the methotrexate depending upon the condition of the patient. Preparation, you can easily do it within 2 months. Beta HCG, this one UPT you will be doing after 14 days. 21 days is for miscarriage. 14 days is for the pregnancy of unknown location. Any other question?